experience of capsular bag implantation AcrySof IOL in highly myopic patients, please.
Dear Chairman, dear colleagues, first I want to apologize that my topic is not closely connected with IOL power calculation. It is how we try to prevent the complications of surgery of highly myopic patients. The most severe complication of cataract surgery in highly myopic patients is retinal detachment. It can occur at any time after surgery, even if prophylactic argon laser coagulation was performed. Why does cataract surgery increase the risk of retinal detachment in highly myopic patients? The decreased thickness of capsular back volume, which is the thickness of crystalline is around 5 millimeters and thickness of IOL is less than 1 millimeter. Increases the vitreous movement and tractions. It leads to horseshoe lesions and retinal detachment. The incidence of complications is high after YAG laser capsulotomy. The idea of in-bag placing of IOL with angled haptics was to enlarge the volume of capsular bag and to move the posterior capsule backward to decrease the movements of vitreous, vitreoretinal tractions, and the risk of retinal detachment. In historical review, more than 20 years ago in Russia, in Sviatoslav Fedorov Eye Research Institute, the IOL T26 was created with 73 haptics, PMMA unfoldable lens with optic size 5 and loop size 11 millimeters. It was widely used in high myopic patients, but to use it after phaco, it is undesirable because we have to enlarge the entrance up to 6 millimeters. And that's why now the foldable IOLs with 10-degree PMMA haptics is available. It is AcrySof MA60AC of Alcon, soft acrylic foldable lens, multi-piece with optic size 6 and length 13 millimeters. Our purpose was to evaluate effectiveness, safety, and stability of implantation of this IOL, AcrySof MA60AC, into the capsular bag of highly myopic patients and to assess the number of YAG laser capsulotomies and retinal detachments. 52 highly myopic patients, average age 56 years, cataract density 2-4+, underwent cataract surgery, phaco emulsification. Their mean spherical equivalent was 10 diopters and mean axial length 27 millimeters. In cases of severe retinal degeneration, argon laser retinopexy was performed in 3 cases. This is the short video of our cataract surgery. All procedures were performed by 2 surgeons using legacy Alcon. After 2.8 clear corneal incision, curvilinear capsular axis measuring approximately 5 millimeters in diameter was performed by forceps. After hydrodissection and rotation of the nucleus, intercapsular phaco emulsification and aspiration of residual cortex were performed. To avoid eventual YAG capsulotomy, the posterior capsule was meticulously cleaned, and then we enlarged the incision up to 3.2 millimeters. The lens was folded across 6 to 12 o'clock meridian and placed into the anterior chamber with the forceps. You see that the leading haptics was initially placed in bag, and the position of the second haptic had to be sometimes corrected with a hook. We had 31 cases of uneventual surgeries, and the IOL was placed in bag. And unfortunately, we had 1 case of posterior capsule tear. We performed anterior vitrectomy, and the lens was placed into sulcus. In all cases of uneventual phaco, the lens was implanted in capsular bag, and we carried follow-up examinations at 1 and 6 months and 1 year. We observed good refractive and functional results, lens stability and centration. The poor visual outcome in some patients was based upon severe retinal degeneration. Younger age and shorter axial length were appreciated for better visual outcome. The level of intraocular pressure was around normal meanings. We observed low frequency of posterior capsular opacities. No YAG laser capsulotomies were needed during the follow-up period. The IOL position was stable. No folds of posterior capsule were observed. There were no retinal detachments after uneventful phaco emulsification, but unfortunately the case of posterior capsule tear led to retinal detachment in 8 months period, and vitreoretinal surgery was performed. And in conclusions, I want to say that in-bag implantation of 10-degree haptics multi-piece AcrySof IOL is stable, safe, and gives good visual results. Implantation of this hydrophobic sharp-edged lens leads to the low rate of YAG laser capsulotomy. The incidence of retinal detachments in cases of uneventual FACA was minimal, and the risk of complications in late postoperative period needs to be investigated. Thank you for your attention.
Thank you very much. The next paper is by Peter Meyer and Zurman from Germany, AcrySof intraocular lens power calculation for the